So my name's Paul Bogner, and I'm a skin pathologist or dermatopathologist here at Roswell Park. And I'm excited to speak to you this morning and grateful to talk to you a little bit about a part of melanoma care that I think less people are familiar with, and that is the role that pathology plays in melanoma care. The kind of bottom line points are that pathology plays a critical role in melanoma diagnosis and treatment. And I am hoping that better understanding that role will help you understand the rest of the melanoma care system, both the big picture and the small details. And so that's my overall goal over the next 20 minutes. So here's this is how we're going to go about it. For those of you that are not particularly familiar with pathology, I'll talk about it briefly in general. And then I'm going to go sort of stepwise through the key kind of roles as I see it that pathology plays. And at the very end, hopefully if I haven't talked too much and run out of time, I'm going to talk about second opinions in pathology and briefly go over the structure of the final pathology report. So the group there on the right side of the screen is sort of the tip of the pathology iceberg here at Roswell. That's the majority of the physicians in our Department of Pathology, but behind those 18 people is another 200 plus dedicated laboratory professionals. That makes us one of the largest departments here at Roswell, and I'm sure it's similar at other hospitals like Roswell. Fundamentally, pathology is a field of medicine using laboratory methods to diagnose disease. And so as physicians, pathologists in part, our job is to guide medical treatment using blood and other tissue samples. And a pathology department uses a bunch of different laboratory methods to do so. Here's the kind of basic rough paradigm. You have a tissue specimen, in this case, let's say a melanoma biopsy, and the pathologist, the star, of course, is involved in taking information from that tissue under the microscope and using other tools to come up with the diagnosis and other important data points that the clinical team then uses to manage the melanoma. Based on that data, the patient might get surgery, might go to medical treatment. If the patient has additional surgery, that in turn may generate more tissue that the star pathologist will evaluate. And so the kind of basic concept here is that the pathologist is extracting information using a variety of tools from the tissue sample to guide treatment. And there are many kind of clinical decisions that are impacted by pathology results. It can impact the need and extent of surgery. It can impact the need and type of medical therapy that's used. And it can also, to some extent, impact how you're followed and what the surveillance is after treatment. Now, we have kind of two basic toolkits that we use for melanoma. The first is the old-fashioned microscope, traditional histology, and in fact, that's still kind of the gold standard and the tool that we use the most. In certain situations, and we've heard a bit about that with BRAF, and I'll talk about it too, we also use modern molecular biology to examine the genetic makeup of melanoma. So the microscope dates back to these fashionable gentlemen. As early as around 1600, the microscope was invented. Now, obviously, my microscope's a lot better than theirs were, but that basic tool is really that old. Now, the genetic tools are clearly much more recent development, and they're useful because melanoma, like many cancers, has an unstable genetic instruction code. And as it grows and replicates, it develops more and more errors. And these errors can come in the form of gains or losses of whole chromosomes, and they can come in the form of specific mutations in genes. Many of these mutations are probably inconsequential, but certainly some of them can be very important, like the BRAF mutation that you've heard so much about already. So let's get down to the nitty-gritty here. How does pathology actually contribute to melanoma care? And I kind of, in my mind, see it as sort of 6 key roles: making or confirming the diagnosis, classifying the melanoma, staging its extent, identifying prognostic markers and treatment targets, verifying the effects of treatment after it's complete, and also managing the tissue. The pathologist is the guardian of the tissue that is removed by surgeons, and we manage that for research and testing. So I don't know if you've noticed, but in medicine we like to use acronyms. Sometimes it helps with long names. Sometimes I think we do it because it makes us seem smart. In the interests of seeming smart, I tried to come up with an acronym that would summarize those points. But MCSIVM didn't work out as being as catchy as I'd hoped. It's also, surprisingly, not even a real Roman numeral, which I thought it might be. So that was kind of a fail. But we're going to start with the M anyway, making the diagnosis. So here are two pigmented lesions. They're actually from the same patient. One is a melanoma, one is just an abnormal mole. So my astute colleagues here, like Dr. Parag, Dr. Ernstoff, Dr. Kame-Puzanoff, they can all look at this, and I'm sure they can probably tell you which they think is the melanoma, and they're almost certainly going to be right in this case. But at the end of the day, they still need to confirm that diagnosis and get additional information from the melanoma so that they can really plan the most appropriate treatment. So they biopsy them. And a few days later, a report comes out of the pathology lab. So what actually happened in the lab there? What happened behind the scenes? Well, I'm going to go through that quickly now. So it starts with the tissue. And on the left there, that's not a melanoma, it's just a little piece of fat that I took a picture of. But it goes into these plastic cassettes that have holes in them. And those cassettes are fixed in formaldehyde, or what we call formalin, neutral buffered formalin. And those go into these machines, like on the right, tissue processors. And overnight, those machines run and remove all the water from the tissue and replace it with paraffin wax. They do this with a bunch of different kind of chemical solutions. The next morning, our very talented histotechnologists take those waxy pieces of tissue and put them in even more wax. So you get these blocks, like on the right, with a bunch of wax and the tissue pieces floating in there. Then they cut very thin sections from those wax blocks. Now these sections are about 5 microns thick. So for comparison purposes, a spider web silk is about 3 to 8 microns thick. So these are very, very thin. And they're so thin that they float very nicely on a water bath like you see on the left. And if you touch a slide to one of those pieces, the piece sticks to the slide, which you can see there in the middle. Now, because it's so thin, it really has no color, and we can't see anything under the microscope if you just leave it like that. So we use 2 different dyes as our standard kind of first step. Hematoxylin, which is kind of purple, and eosin, which is sort of pink. And you can see then a stain slide all the way on the right. So Dr. Ernstoff did a fabulous job showing you kind of a schematic of the skin. And here's a picture from under the microscope of the real thing, with the top being the very outermost surface, the epidermis. And at the bottom, the sort of white area is the fat. And this, under my microscope, is about 20 times normal size. On the screen here, it's obviously much more than that. And so when I'm looking at a skin biopsy like this and we're worried about melanoma, what I'm really doing is mostly looking at where the melanocytes are, what they're doing, how many of them there are, and what they look like. Now, in normal skin, such as this, they're pretty small, they're hard to see, and there's not very many of them. I've circled a couple there. You probably can't tell them from any of the other cells on here. This is probably the first and last pathology selfie you'll ever see. But that's me at my microscope. And if I'm looking at that tissue section there on the right, I can tell you very quickly and with a high level of confidence that this is melanoma. And again, I'm doing this by looking at the melanocytes, which I've circled some of them here for you. Those are the paler cells with maybe a little bit of brown color. I'm looking at each cell, how it looks, how they're growing relative to each other, how they're growing relative to the other structures in the skin, like the epidermis, how many of them there are, how proliferative they are. Those are the kind of features that I'm looking at under the microscope, and this is the gold standard. We can make a very reliable diagnosis in most cases just by doing this. So again, histologic findings are kind of the core of this diagnosis, but it is often critical to also have information about the patient. How old they are, where the lesion came from, and other clinical features like if it's growing, if it's changing, all those things Dr. Parag told you about. Those are useful information points for the pathologist too, so that we have a really accurate overall impression or interpretation. In rare cases, we actually need additional molecular testing. And I'll talk a bit more about that right at the end when we talk about borderline or diagnostically difficult lesions. So we've got a diagnosis now of melanoma. And Dr. Parag talked about the different types of melanoma, and I agree with him. I think this is an underappreciated facet of melanoma diagnosis and melanoma biology. Because as we know, it's a malignant growth of melanocytes. But there really are different types of melanoma that can differ from each other in clinically important ways. And so in many ways, as I see it, it's not really just one disease, it's a bunch of very closely related diseases, sort of like different kinds of apple. And so these are the same kind of types of melanoma that Dr. Parag showed you. And I'm just going to go very briefly and look at number 1 and number 2, superficial spreading and lentigo maligna, to again highlight some of those differences, which Dr. Parag talked about. So as he said, lentigo maligna is more likely to occur at sites of chronic sun damage, long-term daily sun damage. And so for that reason, it's much more likely on the face and neck than superficial spreading melanoma. It's also more likely to occur in older patients, whereas superficial spreading, as you already heard, can impact younger patients too, and is tied to sporadic sunburns in many cases. Importantly, for treatment perspective purposes, superficial spreading is much more likely to have a BRAF mutation. So you can see how classifying this tells us a lot about the potential characteristics, potential response to treatment, and other things. To me, they look different under the microscope too, and so much of when I classify these, it's based on the pattern of the melanocytes, and I'm not going to kind of go into how these look different to me, because I think that would probably be boring for you, but suffice to say that with experience and a little clinical history, you can classify melanoma. The next thing, which Dr. Ernstoff covered really nicely, is staging the melanoma. And we heard that there's clinical staging and pathologic staging, and what I'm talking about is the pathologic staging. Staging is so important because not only does it provide prognostic information, tell us something about how this melanoma is likely to behave and do, but it affects treatment planning. Many times the appropriate treatment choice depends on the stage of the melanoma. Now, our pathologic staging is based on guidelines developed by an organization called the AJCC, another acronym. And they developed their guidelines based on available scientific evidence. And we heard about the T, the N, and the M. And so I'm just going to show you some actual examples of how the pathologist makes those measurements and contributes to that TNM staging. So this is a large melanoma. It's the sort of pink area in the circle there. Surprisingly or not surprisingly, many melanomas don't look very brown under the microscope, especially after we've stained them with hematoxylin and niacin. So you can't count on seeing brown when you're looking for melanoma. So we talked about the Breslow depth or the Breslow thickness, and this is really, as we heard, one of the critical T staging parameters. And so I'm taking an ocular micrometer. I have a little teeny ruler in my eyepiece of my microscope, and I measure this melanoma from the very top of the skin surface all the way down to its deepest growth. And as Dr. Ernstoff mentioned, we also look for ulceration. So we look for loss of the overlying outer layer of the skin, an ulcer right over the melanoma, and that has a big impact on the stage of the melanoma. So in this particular case, a depth of 8 millimeters, an ulcer means this is a T4B. And that's, again, because it's deeper than 4.1 millimeters and ulcerated. And you can see the other measurements there, and ulcer or absence of ulcer toggles the A or B parameter. We've also heard about the N and the M stage. And we spend a lot of time in pathology looking at these lymph nodes under the microscope to see if tumor has spread there. And here's an example of a lymph node. And at this low power, all those blue cells you see, those are just normal white blood cells that live in the lymph node. But if we look a little more carefully down in that corner, we see, unfortunately, a clump of larger cells that have some brown color to them. And these are metastatic tumor cells. And so the pathologist is going to look at this lymph node very carefully, particularly around the edges of it where tumor is most likely to show up. And in this case, would have identified the metastatic tumor cells. Now, for sentinel lymph nodes, we want to be extra careful that we're detecting any cells that have made it in there. So we use a special stains. This is called immunohistochemistry, and we're looking for proteins or antigens on the melanoma cells. There's a variety that we can look for, Melan-A, S100, SOX10. And this allows us to see even 1 or 2 cells, and they stain brown there, among all the background normal white blood cells, which in this picture are blue. It makes it much easier to see them. So then we get the T, the N, and the M stage, and we put those all together for the overall pathologic stage. If you're T4B, N0, M0, down here, you're going to be an overall stage 2C, for example. So the next step is to identify prognostic markers and treatment targets. When you have a pathology report for a new melanoma diagnosis, in most cases you'll have what we call a synoptic report. And this is a condensed sort of stepwise listing of important data points for the clinical team. Not only the Breslow depth and the stage and things like that, but other findings which tell us something about how that melanoma is behaving, how aggressive it might be. Features like whether it's proliferating rapidly by looking for what we call mitotic figures. Looking for invasion of blood vessels in the skin, looking for invasion around nerves, or looking for how the patient's immune cells are responding. Is there a brisk response or no response at all? These are all data points that provide additional prognostic information to the clinical team. Now, of course, you're hearing a lot about treatment targets and personalized medicine. And so I don't want to, cover this in too much depth because you'll be hearing about it more. But essentially, as we've heard, the proteins or systems in the cancer cells are driving it forward, helping it proliferate and survive. So one of the jobs of pathology is to identify those genetic errors that are allowing these systems to function out of control. This is the kind of picture they put up at scientific meetings, and it almost always makes me sleepy, both because it seems super complicated and probably a little bit boring. But I'm showing it because it shows you how complex these systems are. And Dr. Ernstoff talked about one of the key ones in melanoma. And there's a lot of systems that regulate how cells are controlled. And errors in these systems can then obviously contribute to the cancer cell growth. If we zoom in on this area here, we see that RAF protein that Dr. Ernstoff talked about. And again, if the RAF gene is mutated, you have a BRAF V600 gene mutation, you have an uncontrolled RAF protein. It's like a gas pedal that's stuck on, driving that cancer forward. But if we have the drugs now, like vemurafenib, to shut that protein down, we can stop that system from malfunctioning. But of course, this is only helpful if it's malfunctioning in the first place. So here's the paradigm in another form. The gene mutation leads to an abnormal protein, leads to a broken system, the stuck-on gas pedal, and uncontrolled cancer growth. We throw in that targeted therapy, shuts down the protein, returns that system closer to normal, and stops it from driving the cancer. And that's where the pathology star comes in again, because one of our jobs is to identify those gene mutations in the laboratory. Now, after treatment, obviously, it's useful to know if the treatment has been effective, whether it's surgical or medical treatment. And so we're called upon to verify those effects. Here's the melanoma that I showed you earlier. It was the one on the right that got biopsied in our theoretical discussion. Now, you might imagine that if the surgeon kind of cut it around where those black lines are, and truth is they would go much further around it than I've shown you here, but you might imagine that this would take care of it because, the brown that you can see is not at those lines. But the truth is that melanoma cells are sneaky, and sometimes they extend out beyond what you can easily see by eye or with dermatoscope. And so the surgical team needs to know if they did, in fact, remove all of the melanoma. So what we do in pathology is we get one of these specimens, we actually paint the outside of it with ink. And if you look on the right there, there's two big dots, and between the two dots is the edge of the specimen. And when we go look more closely, you'll see that it is also painted with black ink. And so here's a close-up of that area. And you can kind of see the black ink on the right. That's the paint that we put on there. And in this case, we see the melanoma cells going right up to that ink. So unfortunately, in this case, the melanoma has gone to the ink, gone to what we call the margin, and we know that there's the potential for some to be left in the patient. So usually this means that the surgeon will have to go back and take a little bit more skin to ensure it's completely removed, because obviously that's the goal. After medical treatment, we might need to look to see if the patient has adequately responded to that. So this was a patient who had melanoma that had spread to their lungs, and they were treated with pembrolizumab, one of the immune modulating agents. They had a wonderful response. This pink stuff here is all dead tumor. So the pathologist looks at this and says, I don't see any living tumor cells. This treatment worked really well in this metastatic deposit. Finally, as I mentioned, we manage the tissue, and that's both for research and future testing. With patient consent, melanoma tissue can be used and stored for research, and this is basic research or clinical trials, and we store it in different ways depending so that we fit the needs of all the different types of research that might be going on. And so again, we're sort of the guardians of that tissue, and that's an important part of our role. So for the last couple of minutes, I want to touch briefly on a couple of other things. Second opinions, and then the pathology report. If you'll permit me to become a little philosophical, life and medicine often exists in a spectrum, right? Things aren't necessarily clearly black or white. As pathologists, we're trained to kind of put things into diagnostic categories or compartments. So we try and move that spectrum into discrete kind of categories. And the same is true in melanocytic lesions. You can have the ones that are clearly benign or a little bit atypical, but still benign. You can have the ones that are clearly malignant. But we have a small but problematic area in the middle, sort of a gray zone, where these are not as easily classified under the microscope as clearly benign or clearly malignant. Now, of course, we want to be able to further split those so that the patient gets the right treatment. So how can we go about this? Well, like any other area of medicine, sometimes the most useful tool is just the eye of an experienced and expert opinion. And so a second or expert opinion is a very useful tool in these borderline lesions. Many general pathologists are very good at diagnosing melanoma, but there is a specific sub-branch of pathology, of which I'm a member, dermatopathology, where there's extra training a year or two after residency and you're specializing in skin pathology. So an expert dermatopathologist may be able to look at a borderline lesion and tell you, yes, this actually is malignant, or no, good news, it's not. And a clinical team can request that opinion, the patient can request that opinion, and sometimes the pathologist, the original pathologist, requests that opinion. But it's important to remember that even among experts, there are times when there are differences of opinion in these borderline lesions, and sometimes we do need additional testing, like molecular testing, to kind of try and predict whether it's going to be benign or malignant, or at least give us a sense of how likely it is to be malignant. These are very difficult type of lesion, and they're frustrating for patients and challenging for the clinical team, but these are some of the ways we can resolve it. And finally, because I think I'm running out of time, the pathology report. Now, I know AIM at Melanoma has had prior symposiums, and some of those are on YouTube, and there's a very good discussion from, I think, the Moffitt Cancer Center on the pathology report. So if you're interested in this more, I would refer you to that. The basic components of a pathology report, and this is the end product of all the work we do in pathology. We have the patient information, we have the clinical history provided by the clinical team, we have their best thoughts on what we're dealing with, their preoperative diagnosis, and then the heart is our diagnosis, and that includes the synoptic report I mentioned with the additional data points. Often we'll include a note or a comment describing what we see under the microscope, how it influenced our diagnostic decision, and providing additional information to the clinical team. And then finally, the gross description. And this is really just what the specimen looked like when it first got to the lab, how big it was, what color it was, and that sort of thing before we cut it up and put it in formalin. So, to summarize, the role of pathology in melanoma care is to take all of this information, diagnosis stage, genetic profile, response from the tissue using the microscope and other tools to guide treatment. And that's kind of the core of it. So I hope that was helpful. Thank you.